Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we chat with McPhilimey, a senior respiratory and sleep scientist at Cardio Respiratory Sleep and an independent healthcare consultant. This is the second of two podcasts. Now we step to sleep apnea. What is it?
So sleep apnea is actually it's an umbrella term. So within there you've got what we call obstructive sleep apnea, we've got central sleep apnea, and then you can actually get what's called obesity hypoventilation. And if we're to go through all of those, obstructive sleep apnea, as I mentioned before, is where the actual airways are collapsing. So we see a reduction in airflow and a drop in oxygen levels, or a disruption in actual sleep multiple times throughout the night. Now, if you've got an individual where that's only happened 5 to 15 times an hour, that's mild. But then you have moderate and you have severe, or then you have way beyond severe. Central sleep apnea is where the brain essentially is forgetting to send the signals to the diaphragm to breathe. So actually there's pauses in the breathing. Obstructive, you're still trying to breathe, but the airways are obstructed. They're occluded. And then there's obesity hyperventilation, which is essentially where an individual is so large, or they've got so much mass on them that they actually under breathe during their sleep, what we call hypoventilation, so they're not getting enough air from that.
So on the scale of a mild sleep apnea to quite severe, what kind of breaks in sleep are we looking at per hour?
So we actually have an index. So we have an index called an AHI, which is an apnea-hypopnea index. So an apnea is a full occlusion for at least 10 seconds. A hypopnea is a 30% drop in airflow that either disturbs their sleep or it drops their oxygen by 3%. Now we term that number, divide that number by, so the total amount of those divided by the hours that are actually slept gives us the index of AHI. When that's above 30 per hour, we call that severe sleep apnea. So you can imagine being disrupted in your sleep 30 times per hour. It's almost like every 2 minutes that you're essentially having a micro wake up and you're going back to sleep. So the sleep is very fragmented. So therefore, like I was saying earlier, the depth of sleep you get into isn't too great. So these individuals will typically come in very tired, and they're most likely going to be snoring. Snoring is the first indicator that someone has obstructive sleep apnea. And if you've got snoring with daytime sleepiness, those two together, you can almost say probably 70 to 80% of those individuals might have obstructive sleep apnea. So that instantly puts those individuals at risk. Now, if you're a male, you're twice as likely to have sleep apnea than a female. So if we're talking about the prevalence of obstructive sleep apnea, males over the age of 45, it's now probably 1 in 4 males that actually suffer with obstructive sleep apnea. With females, it's probably more likely to be 1 in 10, maybe 1 in 8 females. But they actually think that females are more underdiagnosed. Now, in medicine, it's usually females will go to their doctors first, but there's a stigma around sleep or sleep apnea per se, or snoring, for example, where females might be a bit more embarrassed about the issues. It's always been deemed in history or looked at as, it's a male thing, men snore, but females snore just as much as males as well. But they don't tend to go to their doctors out of embarrassment. So the research actually suggests that maybe there's an underestimation of the amount of females that have obstructive sleep apnea as well. So typically, if you've got multiple comorbidities, someone who's overweight, someone who's snoring, someone who's got excessive daytime sleepiness, that's instantly going to put them at high risk of having obstructive sleep apnea, and they would require a sleep study. Now, depending on the severity of the sleep apnea, that will tell us about which modality of treatment we're going to use. So we're going to go into treatments. Typically for someone who's mild, you might be just offering something like weight loss. And if they're mild but they only have sleep apnea whilst they're laying on their back in the supine position, then you might get what's called positional therapy. And then there's devices out there or pillows out there that can help support and keep people off their back when they're sleeping, so the quality of the sleep improves. And then when it's more into the moderate or severe sleep apnea, especially if someone's tired, you're looking at what we call CPAP therapy. Now, CPAP therapy, as most people out there have probably seen, is just those machines that basically blow like a pressure of air into your airways to keep the airways open so they don't collapse. And you'll wear a small mask, and a lot of people out there are very scared of these machines, or they think they're going to be loud, noisy, and that's 20 years ago. The technology is really advanced now. They even start themselves. They even send the information across to us from up north, for example, or down south. We can receive that information by 3G or 4G network. But what the machine does, like I say, it keeps the airways open. Now, if you're keeping the airways open, the airways don't collapse. If the airways don't collapse, you don't get this drop in oxygen. The body doesn't get stressed. It gets into those deeper levels of sleep and improves the sleep quality. So I've had patients who have come in, on, for example, if you were to go with an Epworth sleepiness score, anything above 10, you would say someone is definitely oversleepy or overtired in the day. I've had individuals who have had 150 or 130 apneas per hour, who are very severe, who in front of me, you can quite clearly, when I'm talking to them, you can see they're trying to stay awake. They use CPAP for one night. The next day, they wake up and go, wow, that is what sleep's meant to be like. And there's research out there that it can keep you looking young. It protects your heart. It can lower blood pressure. These machines, although they have a bit of a stigma against them, they're potentially life-saving, and definitely the quality of life that you get from using them, it's well worth the investment that the cost. And the cost of the machines vary. You have what we call auto CPAP. So auto CPAP means that it regulates itself. It changes the pressure and matches to your needs. So every 5 breaths you take, it might increase or decrease the pressure according to your needs. They're more expensive machines, and they're maybe $1,800 to $2,000. Whereas you've got a fixed pressure machine, which is the old school method of a bit of a constant pressure, who are a bit of a cheaper machine. They can both treat each other, and it depends on the result. Depends on what we would recommend is actually trialing them. So we do have we do trials with these machines. So usually it's either 2 to 4 weeks to make sure that actually the settings are correct. You get the right mask, you get comfortable, and also to coach and help you through that. So it's not about just treating, it's about making it an experience for the individual. Because the most common issue that we have when it comes to treating these sort of obstructive sleep apnea particularly, is the perception that people have when they walk through the door. Most people are coming in, but like, number one, they're tired and they're sleepy. And number two, it does affect mood. Having poor sleep, everyone, when they've woke up in the morning, they've had a bad night's sleep, they feel more, they feel more in a bit of a bad mood. And we know that from the literature. The literature does change the parts of the brain that we do use. So we do have a part of our brain called the amygdala, which is that irrational part of the brain. When we have poor sleep, that is actually, that part of the brain is more activated more. So it's like we become more irrational. So these individuals that we typically see might not be the easiest patients to convert into having to use it. All of a sudden they've gone from 50, 60 years not having to sleep with anything to having to use this machine and a mask on their face. So they're instantly coming with resistance. So what you need to do is you need to make sure this is an experience from where it's actually, they're confident that they're going to get a result. There's consistency in there, and they know and are educated. And that's where what I love about Cardio Respiratory Sleep, the company I work for, is we're not just technically giving the data and say this is what it is. We're actually educating them like we are now having this podcast. We're having a similar conversation with the patient to make sure that they're educated and they're aware of the processes, they're aware of what's going on with their health, so they can make a decision for themselves on whether that modality of treatment is right. There are also other treatments. So, like I say, these machines for some individuals, some people just can't tolerate them. And if it's too difficult for them, there are other things. So we have mandibular advancement splints, and they are essentially like a gum shield or a guard that you wear in your mouth that actually pulls the lower jaw forward, and it creates a space at the back of the airway that keeps the airway open. So that is the gold standard is always CPAP, but for people who can't tolerate CPAP therapy, or actually maybe don't get the benefit from it, or they're maybe only mild to moderate and they don't necessarily need it, then we can look at more mandibular advancement splints. And there's a lot of research going out there at the moment, and we're actually going to be starting to do some research actually here at Hollywood Hospital in Netherlands over here in Perth, where we're actually investigating the efficacy of these mandibular advancement splits, but more dental made ones, so very, very high-end specific to treat you from a medical condition rather than just a social condition which people look at obstructive sleep apnea as being. if it's chronic, so obstructive sleep apnea often doesn't get picked up immediately. People just feel tired. They go, okay, this is just a part of aging. This is just how I feel. And what happens is we actually get a shift in how our nervous system works. So if we're to go being into the science of it, there's actually a nerve called our vagus nerve in our body, and that nerve has 80% of that nerve has these endings that are scattered all around the body that are to detect how our body's feeling. So it's given us body awareness, and it's also given us self-awareness. Now, when we're in this sympathetic overdrive, and we discussed that earlier, so we're getting a reduction in our airflow, we're getting a decrease in our oxygen levels, we get sympathetic activity. When that happens chronically, we get a decrease in this parasympathetic nervous system. The vagus nerve actually is what is controls the parasympathetic nervous system. So we lose control of this vagus nerve. So all those endings, all those nerve endings that are telling us how body aware and self-aware we are, they stop receiving the signals and send it to the brain. So people actually become less self-aware and less body aware. So people don't go, okay, well, I actually don't feel tired. But they might have 30 to 40, 50 apneas a day. But it's like they don't notice a difference. I don't feel a difference. Now, if I was to look at a longitudinal study, whether CPAP improves that, there's no evidence out there because they haven't done those studies yet. But what we do know is that those individuals are still going to be getting the oxygen levels they need. They're going to be keeping their airways open. And under the scenes or behind the scenes where they're not actually feeling it, there is a protective mechanism of these devices as well. Another common sign, especially in typically maybe more senior individuals, of actually having obstructive sleep apnea is frequently having to go to the toilet. So I actually see a lot of patients who always say to me, I've had prostate issues, I've always have to go to the toilet in the evenings, it's part of aging. And then when we get them onto CPAP therapy, they actually realise that they don't have to go to the toilet as much. We know it's a symptom of having obstructive sleep apnea. However, I guess in a way to look at that would be to try and limit the amount of fluid someone is consuming later on in the evenings. Obviously, you have to make sure you stay hydrated, especially we're in a warm country. It's even hotter up north. We need to make sure that we are staying hydrated. But 4, 5, 6 p.m., just being more aware of the amount of fluids that water and caffeines and drinks like that, because that can disrupt your sleep quality. So having to get up quite frequently in the night can cause poor quality sleep. In terms of actually drinks that you can drink to improve your sleep quality, there are some herbal teas, so chamomile tea, and I think there's one called valerian that actually there's a small amount of research to suggest that can maybe just have a calming effect on the body. But I would more, if I was looking at that sort of thing, I would more look at it as a behaviour. Now, if you ask any individual, and the majority of individuals, whether you actually have a sleep habit before they go to bed, most people will say no. I do whatever I need to do, and then I'll just pop off to bed, or I'll watch TV and I go to bed. Now, I look at the behaviour of individuals and say, okay, right, let's dim the lights down. That's the first phase of your first habit that you're going to do. Number 2 is then saying, roughly an hour before your bed, you're going to switch your phone off and you're going to accept that your day's over, no one needs to contact you. And then you're going to maybe do a little bit of reading or some like mindfulness or meditation, and then you're going to go to sleep. So it's making that continual process. So physiologically and psychologically, you're being prepared to, let the end of the day go.
Thanks so much, Martin. It's been a pleasure chatting with you. And if people would like more information, where can they go?
They can actually check out our website, so www.sleepcrs.net.au. There's loads of information on there. So if you're a patient, there's actually information all about sleep apnea. There's information about sleep in general and the impacts they can have and what to look out for on our patient information section. And if you're a GP looking for more information about how to refer an individual for a sleep study, you can check out the referral for doctors section on the website as well.